Welcome. Thank you very much for attending another OrthoIllinois Power Lunch. Today we have Dr. Robin Borchardt, our Medical Director for Occupational Medicine Program, on finding closure for complex work comp cases. We have all seen those employees that we just want to motivate to come to the end of their work comp case and get better and get back to work. And Dr. Borchardt is going to talk about a couple of different ways that you can help with that entire process. Just a couple of things as we go along. I know webinars, as opposed to the in-person stuff right now, has been the way to go. Hopefully we will have an in-person seminar we're hoping for this fall. We're planning that. But so a lot of you have gone to a lot of these. We expect that you understand there's a Q&A button at the bottom right-hand corner, probably bottom right-hand corner of your screen. As we go through, if you do have any questions for Dr. Borchardt, please go ahead and type those in at the very end of the webinar. We will go through those questions and answer as many as we can. Do want to let you know, once we get to that, softballs only, please. We're not obviously going to talk about any specific cases. Following the webinar, for those of you that need continuing education, we will give you a couple of different ways to take advantage of that. The keyword that you will need when you fill out the evaluation is workers. So again, the keyword for that is workers, and we will provide that at the end of the webinar. We also will have right after the webinar, you will go directly to our survey so you can fill that out to get the continuing education, and there will also be a QR code. And if all that fails, none of it should, but if all that fails, tomorrow, 24 hours after we're done, you will all get automatic emails with that information. The evaluations are due by the end of the day on Thursday, just so that you're aware. And welcome, Dr. Borchardt, everyone. This is Dr. Robin Borchardt, our Occupational Medicine Director. Dr. Borchardt, thank you very much for taking your time today. I appreciate it.
Well, thank you, Bill, for having me, and thank you, everyone, for spending your lunch hour with me. Hopefully, everybody has something in front of them to eat, and if you don't, we could give you a few minutes to pick up something. Now, just a general overview, we're going to talk about documentation tips and tricks from the beginning of the injury and as the injury progresses or the treatment progresses. Also, what an employer should look for from the treating physician, and at the end, trying to come to closure and what tools to use and when to use those. Now, from a treating physician standpoint, that initial report of injury is actually a very important piece of information, because as you all have probably realized, sometimes an injury goes 6 months, 9 months, a year, and sometimes longer, and it's like a never-ending story. We start off with a hand injury, it becomes an elbow, up to the shoulder, and then it ends up being a cervical spine injury. So when that injury first starts, instead of just looking at the Form 45, which does not put a lot of detail, if the employer can do an accident investigation, and what that means is basically take the injury in the employee's words and how they see the injury, and also collecting information. So that information can be from fellow coworkers, supervisors, and sometimes pictures will actually help us too. And a lot of companies now have video in their manufacturing, and that is very helpful if you have the injury on video, because with objective documentation, that actually helps us when we evaluate them. We all get employees that come in and say, I lift 50 pounds 100 times an hour, and we find out it's 5 pounds, and they lift it 5 times an hour. So all that information is very helpful. Any history of any old injuries. Now, we ask the employees also if they have any history of old injuries. Now, sometimes the employees are very upfront with us. Sometimes they're not. I've had patients that have had back injuries, and they say they've never had any old injuries, and you examine them, and they have a surgical incision in their lower lumbar spine. But their answer to that is that I had that fixed, so now I don't have a problem. Now, the other big area that we actually would like to hear from the employers is there any other issues? And what I mean by that is sometimes there's issues with the employee and other employees that they work with. Sometimes it's employee supervisor issues. Sometimes the employee's late for work, has an attendance problem, but all those are very helpful, because what you will see or what we see from our end, is employees will get injured and use that injury to manipulate their work. Not necessarily are they looking for a work comp settlement, but they're looking for an easier job and still working and getting paid their full-time wage. Also, they look with an injury, they can modify work with going to therapy, have time off work, and things like that. So, any other issues, because we do see a lot of employers will let us know that, well, so and so just got injured, but we were about to terminate them because they're on their third strike for something else. And then now they use the injury to try and extend their current working situation. Now, when we look at documentation, our big thing is documentation of objective findings. And what I mean by that is we've actually had patients that injured one extremity, and then they come back a couple weeks later and they're complaining about the other extremity. And they said, no, I injured my right arm when I came in here first. Well, no, here's documentation that's your left arm. Even the form that they bring in from their employer, the authorization form says left arm. We also look for that objective findings for consistency of injury. And what I mean by that is if you injure yourself in a certain body part or a certain area, those objective findings should be consistent and be consistent in that area. They should not move up and down the extremity or move across the back from the other side. Because when we first start medical treatment, we do base a lot on the history that the patient gives us. And what I mean by that, that's subjective findings and things like that. If somebody comes in and say they have pain, they hurt their back, pain is a subjective complaint. I have no way of actually measuring that. And if they say they're having muscle spasm, we really do not have a good way of being able to measure spasm in muscle unless you do what's called a surface EMG, which is not available in our area. So we treat the patient a lot of times on what they're actually telling us. Now, we try and evaluate what they're telling us and compare that to the mechanisms of injury, because sometimes their complaints are blown out of proportion to what their mechanism of injury is. And so with the help of the employer telling us the mechanism of injury, it's very helpful because the story that we get from the employee sometimes is not really what has happened. Now, the other issue too is appropriate test ordering. So, and what I mean by that is sometimes you want to do testing earlier than later. And the testing that I'm talking about would be x-rays, MRI scans, CAT scans, and EMGs. And appropriate testing for if you think the patient is going to need surgery should be done as early as possible. And the reason that is it's been shown nationally that if employees feel that they've got good care, it was in a timely fashion, they're less apt to get an attorney and seek legal advice. And if they're going to need surgery, like they tore their rotator cuff or they tore their meniscus or ACL, and you know that on the physical examination on the initial visit, it's appropriate to get the testing because they're going to end up with surgery anyways, and waiting 4 to 6 weeks to get the test, they're already angry and upset because they're not progressing. And of course, they're not progressing because they're a surgical candidate. And sometimes we want to order testing early. And what I mean by that is we'll have patients that just started a job and all of a sudden their hands are numb a week or two later. Well, we'll order an EMG nerve conduction study. And why we order that is to develop carpal tunnel. That's over a period of time. You don't get carpal tunnel in a week or two of working a new job. And if that EMG is positive, that means they have carpal tunnel and that has actually been pre-existing, even though they did not complain of that on their pre-employment physical or there's any documentation of that. Now, when you look at treatment, what we have in front of us is what's called first aid treatment or RICE protocol. Now, what that means under OSHA is that we are not giving any medication, work restrictions, physical therapy, surgery, and if we're providing any bracing or wraps, that those bracings do not have anything that is rigid, which would include a wrist splint that has a aluminum sleeve in it or a plastic sleeve. Now, when we treat them, that includes medications, which for certain injuries can be antibiotics if there's an infection involved, pain control, muscle relaxant, and anti-inflammatories. The biggest medication that we tend to use across the board is anti-inflammatory medications because most of the injuries are an overuse injury, tendinitis injury, a bursitis type injury, and those sort of things. Now, physical therapy is ordered when they have failed some of the simple treatments like activity modification, bracing, work restrictions, and home therapy. Consultations for surgery and other care. Consultations for surgery we actually do very quickly. And what I mean by that is if we perform an MRI scan and someone has a rotator cuff tear, that's going to need surgical intervention. Waiting is not going to improve their outcome, and it also costs you money. The more time that patients are either off work or modified work actually costs money, and they'll also end up with that procedure anyways. So the sooner that gets performed, sooner they get back to regular work, the happier they are, the less money that it costs the employer and their insurance company. Now, when you look at tools to use to try and come to closure, so you have patients that uh, nothing seems to be working or they're getting better, and just before they're getting released back to go back to regular work, now new problems come up or they re-aggravated the old problem. And we see that quite a bit because a lot of patients are at the point that they like doing the light duty work. They're going to work, they're working their 40 hours a week, they haven't taken a pay cut, and they're working less. So when you look at independent medical examinations on some patients that have long chronic injuries, and what I mean by that is we see a lot of people that have had previous back issues. They end up having a mechanism injury that appears to be a simple strain, but they have degenerative disc disease on their MRI scan, and they never get better. And those patients, you like to have their old studies if possible, because if you can compare their old studies to new studies, and there's no change or no acute change that could be attributed to the injury, then a lot of times it's nice to get an independent medical examination to actually confirm that and say they suffered a simple strain, and at this point that strain would be over. Their underlying medical condition now is what's causing their problems. Now, how do you pick the IME physician? Now, nowadays what's happened is we have services that employ physicians, and there's three big ones across the United States, and you contact a service, you pay for an evaluation, and the service actually assigns a physician for that independent medical exam. Now, the issue with the independent medical exam is you will take a lot of times what the physician report says or what the results are, and you have to sometimes live and die by that. So if you get a bad IME or an IME that does not go in the favor that you thought it would, you end up having to work with that because that was your choice to obtain an IME and because of the results. And normally we start doing IMEs and things like that when the case has been going on for a long time. The patient is legally represented, and so we're trying to jump through all the hoops to complete the case. Now, what should you provide an IME physician? And most companies, when their insurance company sets up an IME, the insurance company will set that up. But what you can provide as an employer would be a very detailed, a very detailed description of the injury, and also any pictures or anything of the injury or the situation, because that does help the IME physician also. And what you should ask the IME physician, which most times the insurance company does, is about causality, is about treatment, whether it's been appropriate and indicated for the injury that's performed, and what the expectations for outcome is. Does the patient need surgery? Does the patient need more physical therapy? Or is the patient at what we call maximum medical improvement, which is an insurance term, which basically means that at this time no further treatment is indicated. And if they are at maximum medical improvement, what should be their work status from that point on? Now, work status is what are the functions that they can provide at work and work in a safely manner. And sometimes the IME physician will give us numbers for weights and things like that, but most times nowadays I'll recommend ordering a functional capacity evaluation. So finding closure is summarizing from start to finish. So looking at every injury that you have, getting the documentation up front, and making that your routine is actually the most important thing that can help you go forward. Because a lot of employers, when the case starts going bad, time has went by, they have to go back to scramble to try and get the information. The information is always then sometimes not complete because a lot of times the description of injury when it first happens is totally different than it is 2 weeks later, 6 weeks later, 6 months later. Now, if you have any questions, if you could please type them in, we can hopefully try and answer them for you.
Absolutely. We talked about this earlier. We imagined there was going to be a lot of questions, so we wanted to make sure we had plenty of time to take care of those. Another reminder, as you're typing in those questions, we do have a couple already. Following the webinar, we want you to fill out our evaluation. There will be a keyword that's necessary for you to get continuing education, and that keyword today is workers. Again, that will be on the email. The evaluation link will open up automatically right after this webinar. Just in case you missed it, you will also get a thank you email in about 24 hours, and the link will be provided. All the evaluations will be due by the end of the day on Thursday. Of course, Dr. Borchardt is a very busy guy, and we appreciate his time. If you have other questions you'd like us to direct to Dr. Borchardt, or if you have need more information about workers' compensation, referrals, learn more about our Fast Track program for work-related injuries, you can always look at our website, OrthoIllinois.com, or call us at 815-398-9491. Directly in the Algonquin, Elgin, McHenry, and Greater Chicago area, there's Paul Strandquist, our Business Development Manager. His phone number is 815-847-7088, or you can email him, paulstrandquist@orthoillinois.com, or you can always call me as well. My direct office line, Bill Collar, 815-847-7044, or Bill C. at orthoillinois.com. Drexel's got a question for us. By the way, there is a QR code too. So if you're ANSI and you want your CE, you can actually scan that, and it'll take you right to the evaluation as well. But we've got a bunch of great questions. Drexel has got a great one, and we run into this a lot. What about dealing with pre-existing conditions such as stenosis and degenerative disorders? And I'm assuming these are pre-existing. So I think carpal tunnel, you use that example, or if you've got a degenerative spine, how do you differentiate those pre-existing degenerative conditions from a work-related condition?
So actually, it's a little bit multifactorial. And actually, before I came here, I actually had a patient with the same situation, somebody that's been treated for years for a back issue, quote, had an injury at work that was not witnessed, so it was questionable, hasn't worked at the company but more than 6 months, but it's currently being treated by a pain management person and gets treated every quarterly. But of course, the patient didn't completely disclose all the history of her back injury at the time of employment. She said she had some back issues, but never really spelled it out. So first question would be, did that patient give fraudulent information? Well, she did disclose that she had some back issues, but didn't really disclose the extent. So then what we ended up having to do is her symptoms did not objectively correlate to a specific dermatome with her back. We were finally able to get her old MRI scan and had the radiologist compare it to her new MRI scan. And of course, there was no change whatsoever. So then, of course, at this time we released her. I released her today and said, from your back injury, your strain, you've actually completed your care for that. And she stated, well, I'm no better and I have all these new symptoms. And as I explained to her, at this time with your MRI scan, nothing has changed, and you need to go back to your treating physician. Well, of course, she told me she's already discussed this with her attorney, and she was going to proceed on because work actually hurt her. Now, what will end up happening with this case would be the employer or insurance company should get an IME to confirm that or be consistent with what we have told her. And then a lot of times what happens is this ends up getting settled either in court or between the attorneys from the insurance company and her attorney.
So how is that then related to pre-employment testing? So I know one of the things that you and I've talked about is those employers that want to test their pre-employment for everything under the sun, including carpal tunnel, getting some of those surface carpal tunnel EMGs, which I know you're not a big fan of, so I'll let you go on with that. But how does that relate to some of the pre-employment testing that you're doing?
Well, pre-employment testing, the biggest part of pre-employment testing is the history, because not in Illinois, in other states, if you have a fraudulent information from to get hired for a job and you have a previous injury and then you re-injure it, other states do not. The employer does not have to cover those injuries. In the state of Illinois, if they're injured on the job, even though they lied on their gave fraudulent information on their pre-employment, you still have to treat them. But you can actually release them from employment because they were fraudulent on their application. Now, when you look at pre-employment testing, there is lift testing. There's various stages or degrees. And what I mean by that is we have a lot of employers that do heavy stuff, say the garbage industry, and we actually put them through a pretty intensive lifting thing with our physical therapists. So we know they can lift up to 100 pounds, they can do this, they can do that, at least for the time that we're seeing. The issue always with pre-employment testing is you're testing somebody for 15 minutes to a half hour, and they have to work 40 hours or more doing the same job, which is two different things. Now, when you look at carpal tunnel testing, the gold standard for carpal tunnel testing is an EMG nerve conduction study. Now, a lot of places do what's called a surface EMG and charge for it, and we've basically stopped doing that back in the early 2000s because it wasn't accurate enough to pick up carpal tunnel. I've had patients that came in after working at a job for a couple weeks, numb, and they had a surface EMG that said they were normal at one of the clinics, and you do an EMG and they have severe carpal tunnel. That's probably been pre-existing for at least 6 months to a year. So you do have to look at what your pre-employment testing will tell you and what your expectations are of that testing.
Got it. Great answer. Carrie's got a great question too. So as far as preferences, we talk a lot about communication with the employers. Carrie wanted to know if you have a preference on how to receive the company's concerns or additional information. She says, typically we call this information into your office and it's included in the file notes. Do you have a preference kind of how that information comes in?
Well, our office, I talk a lot directly to a lot of employers, but we also have our work comp ladies, Diane, Jeannie, Sarah, and Lisa, and then Pam does a lot of contact with the companies with some of the drug testing and stuff. So going through them, they're very good about following through, and I do get all the information from them. So whatever is convenient for the employer, because one of the issues, as Bill said earlier, sometimes I'm too busy, and it's a lot easier to talk to them first, and then if I have to get back, because I do try and get back to everybody, because it is important to kind of have that communication to know what's actually going on.
And Paul and I too, I always tell people we try and be the easy button for you as well. So if we've got a lot of different opportunities, and if anybody needs our direct contact list too, so you can directly contact our work comp department or Pam or Sue or anybody that you deal with on a daily basis, please just let me know and I'll make sure that you've got updated contact information. But Paul and I are always options. If you don't know who to go to, we can kind of help direct you to the right spot. Mary Jo's got another great question. So how can you ensure that you ask the right questions and obtain the specifics for each injury to be proactive? Is there a listing or some kind of checklist that you can use?
I mean, from the employer standpoint?
I would assume from the employer standpoint.
From the employer standpoint, I mean, what we see a lot, and not every employer is like this, but we'll see some of the Form 45 reports, and I hurt my back, and then it says I hurt my back lifting something heavy. What the employer can ask, and because you guys know what that position entails, what they're actually doing, what we ask the employee is, okay, do you know how heavy this was? Do you lift this on a regular basis? Is this a normal part of your position? And okay, if it is, then why today is it hurting you? What did you do differently? Did you do that process in a way that was detrimental or not, in a way that you're not supposed to do it? So asking all those questions, and actually pictures actually make a big difference too. And I've had companies go out and I'd ask them to actually weigh the object or part that the patient's saying this is how much it weighs, and there's a lot of times where that weight is significantly different than what the employee said.
And we had a great meeting yesterday with a group, and we talked about that, especially videos of jobs. So the example that came up yesterday, so if you have proprietary information or something that is going on in that particular job, if you can have a video of someone doing an approximation of that job, is that beneficial to be able to take a look at that?
Absolutely. And a lot of companies over the last 10 years, because of iPhones and the phones, you can go out with your phone and if you videotape the position of the job. Now, what actually is very helpful too, and I've had some employers do this, go out with the employee, look at the job at the time they report it. Now, that's only helpful a lot of times when they come in and tell you right away, not when they tell you 4 weeks or 6 weeks later that I hurt my back over here. But if you go out to the job and you have them show you, you take a 2-minute video on your phone and save it. I get sent a lot of videos via email because you can download them or by text message of the jobs, and that is so helpful because a picture is always worth 1,000 words.
Lisa's got a great question too, and this came up, and this has come up a lot in a couple of recent meetings. What are what are the objective findings found on diagnostic imaging that alert you to an acute injury versus, say, a more chronic injury?
So when you look at especially MRI scans, so MRI scan is probably the imaging for acute injuries, and why that is MRI scan actually will show fluid, and what fluid means edema or swelling. Bones can actually have fluid or have edema and swelling, and you can actually see that on an MRI scan. You can't see that on a CAT scan or X-ray. The other thing on MRI scan too is when they do an MRI scan on a lumbar spine, they'll say no acute findings. Well, no acute findings because they don't see any signs of any edema or swelling, and they'll also see bone spurs, and they'll see things that are considered degenerative. So that's what actually we look for.
I'm going to feed you. I know what the answer to this, but how important is a good MRI read to you as a treating physician?
Oh, very important. So we look at a lot of MRI scan reads, and we do have a lot of MRI scans actually overread. And why we have them overread is, we have the history of the patient. We are looking at the patient, and sometimes what the radiologist is saying is not adding up to what I'm seeing, or I'm looking for something else, and the radiologist didn't even mention that. And I do review all the MRI scans myself. I also go through them with my partners. I also actually show all the patients their own MRI scans. We want them to see the pictures. We give them a report so they have that. And like with this case today that I just saw prior to coming here, I actually called the radiologist because he didn't specifically say that there was no change and that he compared it to her last 2 MRI scans. So he prepared a report that said, yes, I looked at this MRI scan from this date, this one from this date, compared it to the new MRI scan, and there is no change. And that is very helpful because she was not happy with that, but the MRI scan, there was no change.
Yeah, if you have access to an old MRI scan, something that can be
Huge, yeah.
compared, hugely important.
And some MRI scan pictures are better than others, and it depends on where people go. Some reads are better than others. And what I mean by reads is if we all went out and looked at the sky, some of us would say it's blue, some would say it's gray because it hasn't started raining yet. And if you take 3 radiologists and you have them read the MRI scan, you'll get 3 different reads.
And some of those, if the radiologist read on the MRI is really, really short, that's not necessarily a good thing.
Correct.
How about with IMEs and FCEs? Those aren't, while those are really helpful tools, they're not without their consequences. You sort of have to, you live by what is given to you at the end of those, right?
Well, the issue when you start out with functional capacity evaluations is they've changed over the years. And what I mean by that, 10 years or longer, people were actually, an FCE was done over a 2-day period. And what I mean by 2-day is you did some testing one day, then you brought them back a day or 2 days later. Now, why that is done is one of the things you look for in FCE is what's called validity testing. And what that means is this patient sandbagging us? And with validity testing, you're looking for them doing the same thing consistently. And what the patient doesn't understand is they are doing the same thing multiple times, but in different ways. So when you get them being able to lift up, oh, I can only lift 5 pounds, and then this other way they lift 35 pounds, that changes their coefficient of variation. And the higher coefficient of variation, the FC is invalid, which means that the patient is actually trying to sandbag the FCE. Nowadays, you get a 3-hour FCE, and if you don't have good validity testing, you get a wait, and you have to live and die by that FCE, especially if they're represented. And that's the downside of the FCE, especially because the FCE is not a perfect test. I can actually go in and take our FCE and actually get rated on a very low weight and have permanent restrictions because I know how it works. Now, when you look at independent medical examinations in the old days, we'd say, okay, for this sort of thing, it's a spine thing, we send it to Dr. A. If it's a hand thing, we send it to Dr. B. Like I said, most insurance companies, everything is becoming, you have a service, and now, like I said, there's 3 big services in the United States, and they just employ physicians. Now, what's happened with that is a lot of IMEs and a lot of things. It's all about cost. Same with MRI scans. Is sometimes paying cheaper is not better, and sometimes skimping some money on an IME or on a MRI scan could cost you thousands of dollars in a settlement, or with differential in wage payments if they're on permanent restrictions. And so it could be a huge number that you don't consider.
As we're coming to the end of some of the questions, if you do have any other last-minute questions, please feel free to type those in so that we can address those. I do want to give you a little bit of a heads up as well. When you fill out your evaluations, one of the things that we really, really appreciate is suggestions for other webinars. We've got a bunch that we're planning to have in the near future. One of them is to have Rachel, who does our FCEs, do an entire webinar on specifically FCEs and kind of the pearls and pitfalls of that as well. So I will give you more information as soon as we've got that planned. Got another question from Ryan. So Ryan asks, some doctors try to assert that the MRI has to be done in their office instead of an outside in-network facility. Is it preferable that a pre-existing MRI and new MRI be done at the same MRI facility for comparison purposes, or does it not really make any difference as long as the quality, magnet strength, Tesla, is similar?
You're correct at the end of your question. It's got to be a quality MRI scan no matter who performs that. Whether or not it's performed at 2 different sites does not make any difference as long as the MRI scans are of good quality.
And Mary Jo has a great question, Mary Jo. This is something that has caused a lot of discussions in the pod. We all have those frequent flyers, some chronic abusers of workers' comp. How can the employer or the case manager advise you as they question the validity of the claim?
There's a couple different ways you can do that. And what I mean by that is the employer, if you're communicating with us right in at the beginning of the injury, because we do get employers that communicate with us. We recognize the frequent flyers that we've seen before, but we get a lot of new people, and then we find out from the employer or from the adjuster that this is their 6th or 7th work comp case. Now, you can get a little flare of that when you first talk to patients because you can recognize what's called the educated consumer in the work comp place because of the questions they ask, and they're very specific about what they want in their paperwork and all that sort of thing. So that information is actually very helpful. Now, when you look at workers' comp, everybody is always thinking somebody's out for a big settlement and that's what they want, but the majority of workers' comp is the worker trying to change their work situation. Now, whether that be not be at work because they have family issues, whether that be at work, be on light duty so they're getting paid their regular paycheck but don't have to work as hard. Those are the most common things that we actually see.
How about, can you talk a little bit about causation? Because I know that obviously causation is something that you're looking for as you're evaluating that employee, and that is something the employers want, as soon as possible. Talk a little bit about, if you can, the you can't always get causation the moment the patient or the employee walks in the door and says, I'm injured. Talk a little bit about the process you use to determine
Well,
causation.
it's very easy when somebody uses a box cutter and cuts their finger and you suture it up. When you look at patients, and we see a lot of patients with extremity discomfort, which could be tendonitis, could be cumulative trauma, that sort of thing. And so, like I said earlier, in medicine, we base a lot of our treatment on what the patient's telling you because there's no good test to actually identify that. So the subjective complaints come into play and whether or not they're consistent. And you'll see sometimes in our report, subjective complaints are not consistent with objective findings. And so you try and go through that, you examine the patient. Sometimes we examine them a few times because we want to get an idea of the consistency. A lot of tendonitis, bursitis, or strains, those diagnoses are not based on any objective information unless you see swelling, you feel crepitus, you see discoloration or erythema. They're based on what the patient's telling you, based on what you're seeing on their physical exam, and also their mechanism of injury. Is it all consistent?
Got it. Great. We've gone through all our questions. If anybody has a last minute question, please feel free. There we go. We got another one. So Drexel asks, what about an employee? What about when an employee doctor shops? This is a good one, and goes to a questionable treatment center, is either a massage therapist or maybe a chiropractor that's claiming to operate a center without medical records. I guess the question is, what about, we'd start with the doctor shopping. What if they have a relationship with a physician that they know is going to rule in their favor? How do you address that?
Well, everybody knows that Illinois is not an employer-directed state, so they do have a choice of treating provider or physician. And technically, the employers can't really send people to a specific place, but you can kind of nudge them over, so to speak. And the patients that are educated consumers, they realize that right away because we kind of go through the criteria about what takes you off work, what doesn't, because a lot of them come in and I need to be off work. Well, no, you really don't. You're not incapacitated. And they know that if they get a note from their doctor, that'll just pull them off work. Now, from an employer standpoint, those situations in the old days, the employer would say, well, I've got a note here that says you can come in and do modified work, and if you don't come in, we don't have to pay you. Now, a lot of employers nowadays are much more, resistant to actually doing that. They'll say, well, this doctor says they could be off work, so we're going to let them off work. Well, when you do that, you're just reinforcing that employee's behavior, and there's nothing illegal about saying, look, we have work for you. If you don't want to come in, then that's fine. You're going to use your vacation time, whatever, or take FMLA leave period. So.
Any closing thoughts? Anything else that you want to cover after all those questions? Something else that came up?
Well, workers' comp, I've been doing it since the early 1990s, and it has changed. The state of Illinois had some law changes, back in 2011. There actually probably needs to be more, but it probably won't ever happen. Is the only thing, because the big issue that we have and that the employers see is pre-existing conditions. And Illinois, if you have a good attorney, you can get you can get hit with an exacerbation or aggravation of a pre-existing.
Got it. Well, thank you so much for your time. I know how busy you are. You probably have a line out the door, so we're going to let you get back to clinic.
Thank you, Bill,
here.
for doing all this. It
Absolutely.
came out very well.
Very good. Again, my contact information is right there at the bottom of the screen, along with Paul in our Eastern Division, Algonquin, Elgin, McHenry in the greater Chicago area, or in North Central Illinois and Rockford. Feel free to give me a call. Thank you so much for your time. We appreciate your time today, and we hope you all have a wonderful day. Thanks.